Hi, my name's Zing. I'm one of the Electrophysiology Fellows currently at Westmead. Today I'll be giving a talk about pulse field ablation. To understand pulse field ablation or electroporation, first we need to go back and review a bit of cellular biology. Cell membranes are made up of lipid bilayers that are largely non-conductive structures. The transmembrane voltage of a cell is maintained through a complex array of membrane ion channels and pumps which are found housed within the cell membrane. Maintenance of this cellular bilayer and also the transmembrane voltage itself is critical to the function of the cell. Electroporation is the phenomenon where cells are exposed to electric fields of high intensity and short duration. By exposing cells to electrical fields, pores will form within the cellular membrane, which allows the translocation of ions and other particles. Previously, it has been utilized to enhance therapeutics, such as allowing genes to be transfected into cells and also chemotherapeutic agents to be transfected into cells. For these fields, reversible electroporation was the goal, which allowed for transient membrane permeability, allowing the delivery of the therapeutics into the cell and then the recovery of the cell back to full function. For our purposes, we are interested in irreversible electroporation, which results in apoptosis and necrosis of the cells. In this way, we can harness this to target cardiomyocytes that are crucial to sustaining arrhythmias. So the exposure to the high-intensity electric field results in opposing charges gathering on opposite sides of the cell membrane, and once the induced transmembrane voltage reaches a critical threshold, then electroporation occurs. The cell membrane becomes more permeable, forming pores, and the subsequent pulses in each train can stabilize or increase the size of the pores. And once it gets to a critical size, then the membrane is completely destabilized and the cell undergoes apoptosis or necrosis. Larger cells are more susceptible to electroporation, so if we compare cell sizes between myelinated axons, which are found in nerves, and smooth muscle cells, what you can see is that atrial cardiomyocytes are much larger. And this, in turn, means that pulse field ablation or electroporation is more selective for cardiomyocytes and has lower likelihood of causing collateral damage to structures, which is important for the safety profile of PFA, which we will go on to talk about later in this talk. So typical pulse field ablation systems use a DC power supply to charge a capacitor, which is then able to discharge high voltage between two or more electrodes, creating an electrical field. The electrical field strength can be modulated by increasing the voltage, as can the number of pulses and pulse repetition rate, as well as pulse duration. All are modulated by the generator itself. The exact secret sauce behind all of these different waveforms is something that's proprietary to the companies, and we don't really know how they are adjusting the various knobs and dials. But essentially, the most important thing to take from this is that you can tailor all of these variables for different applications within the heart to achieve irreversible electroporation. Essentially, all these variables can be adjusted such that you can maximize treatment efficacy while avoiding thermal injury, gaseous microemboli, which can cause stroke, and also arcing between the electrodes, which can cause electrical injury. Unlike cryoballoon ablation or radiofrequency ablation, PFA does not rely on tissue heating to cause damage to the myocardial substrate. It is important, however, to note that heating does occur when electrical fields are applied to cells, and this heating is increased, as we discussed before, with increasing pulse repetitions and also an increase in the amount of voltage. The heating that is created by pulse field ablation is likely biologically insignificant, with some recent studies showing that heating was detected on an esophageal temperature probe, which was placed at the time of a pulmonary vein isolation, but the temperatures never really rose above 41 degrees Celsius. Pulse field ablation is still reliant on good contact to deliver effective electroporation. The strongest electrical field will be observed in close proximity to the electrodes, and the intensity or strength of the field is related to distance with an inverse square law. Contact is therefore important to achieve effective electroporation, and interestingly, the strongest electroporation effect is observed when the catheter is placed in parallel to the tissue fiber orientation. Currently, most of the preclinical studies are focused on the utilization of bipolar pulse field ablation between two electrodes. This is mainly because it is highly suited for work in the atrial tissue and can achieve transmurality. Unipolar ablation has been looked at in preclinical studies, and it's been shown that it can achieve greater lesion depth, but at the cost of more heating, skeletal muscle stimulation, and pain. Another thing to note with bipolar ablation is that if the electrodes are too closely spaced, it can cause electrical arcing. Therefore, we have to take care when we're deploying these catheters within the heart and make sure that we're happy with the positioning on either fluoroscopy or 3D mapping. We'll now go on to talk about procedural workflow with the pulse field ablation catheter. Pulse field ablation remains in its infancy with only first generation technologies being available. The size of the pulse field ablation catheters is quite large and require large bore sheaths within the vein to advance advance the equipment up into the heart. Ultrasound guidance is therefore of utmost importance when achieving vascular access to minimize the risk of vascular complications. Once access has been obtained, it is important to confirm that the wire is in the vein either via fluoroscopy or ultrasound visualization before advancing these sheaths. Further to this is that consideration must be given to closure devices such as a perclose or a figure of 8 stitch, such as what is seen in the figure below, to reduce the risk of vascular complications and aid in hemostasis given the size of the sheath utilized during pulse field ablation. Care must be taken when advancing the catheters up into the heart due to its size to prevent vascular injury both at the groin and also within the abdominal or thoracic vena cava. Our current experience at Westmead Hospital using pulse field ablation is primarily using the Boston Scientific Farapulse system and a fluoroless approach. The FARAWAVE catheter has a pentaspline design which can be deployed in either a basket or a flower. Originally, a straight-tipped wire was used with this catheter to advance it up to IVC across the transeptal and into the pulmonary veins, but this was associated with an increased risk of pericardial tamponade and intrabronchial bleeding. We now use a J-tipped wire preferentially to advance this catheter up into the heart. Our current setup with the Farapulse catheter is that we firstly get a single transeptal, which is achieved either under transesophageal echocardiography or intracardiac echocardiography guidance, as can be seen in the video on the right, showing the right atrium in the near field, left atrium in the far field with the catheter being placed more distally. We advance the FARADrive sheath across the wire into the left atrium after the transeptal has been established, and then put a mapping catheter up the FARADrive sheath. The veins are mapped and the geometry is then established. The mapping catheter is then exchanged for the FARAWAVE ablation catheter, and the J-tipped wire is advanced sequentially into each of the pulmonary veins. Once the FARAWAVE catheter is placed into the antrum of the pulmonary veins, we can actually see the orientation of the catheter, where each of the splines are depicted numerically, and also the configuration of the catheter changes based on whether it's in a basket or flower configuration. A profound vagal response is quite common with pulse field ablation, and we usually give atropine 600 micrograms IV prior to any pulse field ablation to prevent any slowing of the sinus rate and AV block and significant bradycardia. Once the catheter is positioned appropriately, the magnet must be switched off with the Carto system to prevent any damage during PFA delivery. As you can see from the EGMs, after each ablation, there is quite a significant amount of washout and artifacts on the recording software. Our clinical practice at the moment is to give 4 pulses in total for each vein, so 2 in each configuration in each of the pulmonary veins. Between each of these 2, we usually rotate the catheter at least 30 to 40 degrees to cover the entire circumference of the vein. Our clinical practice at present is also to give 2 additional pulses in basket over the carina, and in patients with persistent atrial fibrillation, further pulses to isolate the posterior wall can also be considered.